Behind the posterior wall of the pterygoid, when it is pneumatized, pterygoid recess, or when it is pterygoid trigon, if we drill from anterior to posterior here, in the posterior leaf, I will show you another example. Posterior in the pterygoid trigon, you have visceral carotid. This is also very important point. You have to track this medial canal, which is in line with medial pterygoid plate, and it goes laterally. So this medial nerve goes laterally. That is very important point. Next. This one is the posterior choana. This is right choana, left choana. And when you don't have any landmark in the nose surgery, in your revision surgeries, extensive chondrosarcomas or chondromas, or when you revision nasal malignancies, when you don't have any landmark, your posterior choana itself is a landmark. The lateral part of the posterior choana is in line with medial pterygoid plate. And so lateral part of the posterior choana, medial pterygoid plate, medial canal, paraclavial carotid are in line. And again, in revision surgeries, extensive malignancies or extensive tumors, your midline itself, your septum itself is a landmark. Suppose extensive clival chordoma, clival tumor is there. Stay in the midline, remove the keel, or when the keel is also necrosed, we don't have any landmark, your septum itself is a landmark. And this is the ula and the tonsil, tongue. This is the parapharyngeal carotid. Sometimes it goes behind the posterior pillar, and you can see when you are doing the tonsil surgery also here. And usually it comes like this. The eustachian tube. The eustachian tube starts at precochlear carotid and horizontal carotid junction. So we are seeing this at routine medial surgeries. It goes behind the pterygoid plates and stays, the pharyngeal opening end stays behind the medial pterygoid plate. So the final conclusion point is medial pterygoid plate and the pharyngeal opening of the eustachian tube, medial canal, paraclavial carotid. This is the core point of anterskull base. Next is the IJV. When we are seeing in the anterskull base, it stays posterior to our carotid canal, jugular bulb, and this is the IJV. And the mandible. Next, two cones present in eye. One, this cone, suppose for mnemonic sake I am saying this is ice cream cone. So this blunt end present medial to this paracellular carotid. So this blunt end is the nasal part of, that is our sphenoidal part of superior orbital fissure. This is the superior orbital fissure. And above this is the optic canal. And this ring is common tendinous ring. Now, the space between this optic canal and the superior orbital fissure is called optic strut. In mechanical, in physical, in engineering terminology, this is called column. This is called strut. See the shape here. It is strut. It is like this. Neurosurgeons, they call this as posterior root. The limmatization of this optic strut or posterior root, what we call LOCR, lateral opticocarotids. So the three terminologies, posterior root of anteroclinic process is equal to optic strut is equal to LOCR. And the space between, the bone between foramen rotundum V2 and the superior orbital fissure is called maxillary strut. So again the statement, superior orbital fissure stays between optic strut and maxillary strut. Superior orbital fissure present between two struts, and this is the inferior orbital fissure. And styloid process and three muscles: stylo pharyngeus muscle, styloglossus muscle, stylohyoid muscles. I will tell you the significance in further diagrams. For the time being, just remember that though these are small muscles, they are contributing, they are protecting the great vessels. and temporalis major. This is the medial pterygoid plate. Origin from the medial end of the condyle, it is going in between the pterygoid plates. So in JNA, when the tumor extended, eroded the pterygoid plates, you can see the muscle and it's bleeding. You have to coagulate or do whatever you do, cauterize it in the pterygoid plates. That is good. Yes. Sir,
yeah.
One bigger picture here.
No. That will supply not support. It's like your time and picture.
So, another. This is the superior orbital fissure, this is the inferior orbital fissure. So, the bone between the superior orbital fissure and inferior orbital fissure is greater ring of sphenoid. So, this is optic canal, optic rim. This is optic rim. So, there are 4 semilunar lines. 1, 2, 3, 4. The first above one is orbital surface of frontal bone. This lateral one is orbital surface of zygomatic bone. Below one is orbital surface of maxillary bone. That is orbital surface of ithmoid bone, nothing but the lamina papricica. The bone between superior orbital fissure and inferior orbital fissure is greater ring of sphenoid. The bone above the superior orbital fissure is lesser ring of sphenoid. So, in endoscopic transorbital approaches, if you pass this greater ring of sphenoid, you can go to middle cranial fossa. Suppose if a tumor present in the orbit, it extends into the middle cranial fossa. Again, there is no need to open here. You can directly endoscopically, you build the greater ring of sphenoid, you will reach the middle cranial fossa. The lesser ring of sphenoid, that and optic canal, that also you will reach the middle cranial fossa. So superior, that is superior to superior orbital fissure, lesser ring, inferior is the greater ring of the sphenoid. This is the final diagram. I will find conclusion. Only 2 bisections in the whole skull base. Greater ring, GSPN bisects the petrous carotid. Very important point in middle cranial fossa approaches. Greater ring of sphenoid bisects the petrous carotid. See here in the first diagram, it is crossing laterally the laceral carotid. Our GSPN is nothing but the median canal. So, in the opposite diagram, GSPN, that is middle cranial fossa approach, GSPN bisects the petrous carotid and bisects the V3 also. And the first diagram, the vertical part of the facial nerve bisects the jugular bulb. This is again a very important point in our glomus surgery. So only 2 bisections in the whole skull base. Pterygopalatine fossa. So the medial one is sphenoidal process and orbital process of the palatine bone. This is pterygomaxillary fissure. From back to front, we are getting V2 and medial nerve. So, and the superior medial part is only the pterygopalatine fossa. We may think that the whole posterior wall or whole medial wall is the medial half is the pterygopalatine fossa, but it is the only superior medial part is the pterygopalatine fossa. And superior medial inferior is occupied by the pyramidal process of the palatine bone. So that is the relation between the palatine bone, the vertical perpendicular plate and horizontal plate and the pyramidal process, and that is the pterygopalatine fossa. So the difference between the pterygopalatine fossa and infratemporal fossa, the division is marked by our infraorbital nerve. If I see infraorbital nerve, if I track this, I go to the middle cranial fossa. So when I see an infraorbital nerve, I am seeing middle cranial fossa. So it is differentiating the whole posterior wall of the maxilla into medial pterygopalatine fossa and lateral infratemporal fossa. See, infraorbital nerve, if I track, I go to middle cranial fossa. Same. Another. Pterygopalatine fossa extends superiorly to the orbital apex. This is very important. Our JNA goes into the orbital apex. So that is the reason. See here. Pterygopalatine fossa superiorly it extends into the orbital apex. Medially, sphenoidal process, orbital process, Through that we are getting the spinopalatal foramen, and below is the pyramidal process. That side diagram. GSPM becoming median canal.
Hello.
In a lateral skull base, Mariasona lateral skull base or FT mochite, the floor of the sphenoidal sinus is occupied by the median canal. Median canal. So here, this is very important. When we are drilling from anteriorly, it is almost 2 centimeters to reach lateral carotid from the median canal, roughly, or at least more than 1 centimeter. Whereas if you track the V2, it is only 5 mm. It is very near. Your medial canal fossa dura is very near. So that is the medial canal fossa. They say in the first picture. See here, the orbital apex, pterygopalatine fossa extends to the orbital apex. See that X-ray. And pterygopalatine fossa extends to the superior orbital fissure, orbital apex, inferior to the cavernous sinus, bullous muscle. This is antiskull base. So our tumor is going into all this JNA, all this area, because the anatomical position here, that is antiskull base view. Again, this is lateral skull base view. Pterygopalatine fossa extend to the middle can extend to the middle canal fossa, superior to the superior orbital fissure. Both together. Infratemporal fossa. See, this is the only perspective. This is infratemporal fossa in an axial section. Previously, before the discovery of this antiskull base anatomy, lateral skull base surgeons Mariasona, Professor Fish, they designed infratemporal fossa A, B, C, D. A means starting from jugular foramen, jugular valve. B means starting from carotid. So, if you draw arrow from posterior to anterior, it is lateral skull base. If you draw arrow from anterior to posterior, it is antiskull base. So, infratemporal fossa anatomy, from anterior, pterygoid plates, V3, MMA. V3 and MMA like husband and wife. They are together in lateral skull base or antiskull base or transtemporal skull base. When you see MMA, immediately you have to expect V3. When you see V3, immediately you have to expect MMA. So, pterygoid plates, the posterior border of the pterygoid plate, if you track posterior in the lateral skull base, if you track posterior border of the pterygoid plate, it leads you to the V3. So, immediately lateral pterygoid posterior border, I have drawn V3. So, pterygoid plate V3, MMA, joint, carotid artery, cochlea, jugular vein. Only perspective, anterior to posterior, posterior to anterior.
But it is not like this, it is like this.
Which one?
When the jugular is at the lower level, then cochlea is over here.
Roughly. But to understand the concept actually, not exactly.
No.
The maxillary artery, first part, second part, third part, mandibular just behind the mandible, that is the first part of the maxillary artery. So this one. The first part we have MMA, inferior alveolar artery, second part is deep temporal arteries. These deep temporal arteries are main vascular supply to our flaps, all lateral flaps. Yesterday Satish Jains are told all several flaps here. Those two are the muscular flaps from the second part of the AIIMS. The third part, inferior alveolar artery, posterior superior alveolar artery, usually they arise from the same area. And that is median artery sometimes, usually, it arises from the lateral carotid. It may not be present all the time. If at all it presents, it comes from the lateral artery or it comes from the maxillary artery also. And the pharyngeal artery, which goes into the collectovaginal canal, also comes from there. And the spinopalatal artery below is the GPA, greater palatal. This deeper temporal artery, second part. The second part, PDTA and ADTA, are useful for obliteration of the extensive cholesteatomas or extensive tumors, temporalis muscle flaps. And this maxillary artery sometimes it comes in between the two heads of the lateral pterygoid muscle or below. So a little bit variation. It may not be always inferior or always posterior. So this side diagram is the lateral skull base, this is anterior skull base. The V3 MMA, this MMA is going there in both the ways. MMA and inferior alveolar artery, IMAX. Whenever you see V3, immediately you have to expect MMA. And lingual nerve, inferior alveolar nerve. So many years. So V3 and MMA. And these are our JJs, nasal part, infratemporal part, and the posterior pharyngeal part. 1 and 2 you can easily manage with the coagulator. And Satish Jains are also, I have seen for the last 10 days several surgeries. Satish Jains are also managing the third part also with coagulator, but he is taking the carotid control, external carotid control. So third part you have to be very careful. You should not take a chance. You must take this control. This is the core diagram. This is called sphenoid hitch. And horizontal line from the foramen rotunda, horizontal line from the median canal. The space above the horizontal part of horizontal line above V2 is called middle cranial fossa. Below one is infratemporal fossa. And the space, that red triangle is the pterygoid trigone. In a 45-degree angle to VC is the foramen rotundum, that space is the pterygoid trigone. So if there is any CSF leak from the middle cranial fossa, that pterygoid trigone you have to drill. You can't work with the 30-degree scope from sphenoid to laterally. You can't plug it. So trans-pterygoid approach is necessary. This is the core diagram. And the space between this medial pterygoid plate and lateral pterygoid plate is pterygopalatine fossa. Lateral to the V2 is infratemporal fossa. The space above that horizontal line V2 is middle cranial fossa. Same pterygoid trigone, pterygoid recess, and is equal to sphenoid recess. Nematization of pterygoid trigone is pterygoid recess. This is again very important. The posterior wall of the pterygoid trigone is occupied with the lateral carotid. If you look from medially, pterygoid trigone, immediately posterior to the posterior wall of the pterygoid trigone, you have lateral carotid. Very important in extensive JNS. And the palatobasal canal, medial canal and foramen rotundum are in line, in a 45-degree angle line. Superior orbital fissure, all are in 45-degree angle line. Middle pterygoid plate, just behind is our eustachian tube. This medial canal is funnel shaped, you can clearly observe in our endoscopic view. And this V3 is like a horse rider leg. It comes anterior to the petrous carotid. Our GSPN continuation as a median nerve present medial to that and lateral to the lateral carotid. That is called quadrangular space. In middle cranial fossa approach, anterior 1/3 of the petrous bone is again divided into T and Q. There also you get quadrangular bone. 2 Qs are there in the whole skull base. This is called quadrangular space Q, and that is also Q. Can I start? So V3 is perpendicular to V1 and V2. So okay, I will stop here. If you look in the CT scan, lateral pterygoid plate is in line with foramen rotundum. In a lateral skull base, if you follow the lateral pterygoid plate, you will lead to V3. This is useful in endoscopic nasopharyngectomy or external approaches, where you simply follow the posterior border of the lateral pterygoid plate. V3 is automatically comes. Okay, let's stop.
Yeah.
There are so many. There are so many. 300, 400.
I'm sorry to interrupt and come between you and presentations, line diagrams of Murali. But we do have 2 or 3 presentations.
Right. If